So are we hooking them up so we can suction them? Are we hooking them up so we can feed them? For your CPE, you're gonna hook your patient up to suction. The nice thing is the suction numbers are the same as trach, that 80 to 120. The difference is instead of flipping your suction to the regular side where it's gonna be continuous, you're gonna flip your suction to intermittent, and the suction machine itself is gonna come on and turn off, and come on and turn off, come on and turn off. So it's gonna do its own intermittent suction. So when you turn it on, it's gonna go to the intermittent side. So I'm not even gonna worry about the suction machine for now, because until we get this in and we get it set up and we're sure it's in the right spot, we're not gonna hook them up to suction. So in order to do this, you wanna sit your patient up, and I forget our beds only do one thing at a time. And you want this patient to sit as high as possible based on their condition. So if they are awake and they can sit all the way up, I want them to sit all the way up. I'm gonna bring the bed up. It's kind of like trach. I want the patient's nose and mouth to be about eye level so that I can see what I'm doing. Okay. Now, I need to assess bowel sounds, which if we're putting in an NG tube, you may or may not have them. We may be hooking this patient up to suction because they've got an obstruction. The other thing I want to do is I want to look in the patient's mouth, and I want to look at the patient's nose. You want the best nostril when you're putting this tube in, because you want it to easily pass through the back of their throat. So one of the things you're going to want to do is you're going to want to look, push on one side, have them take a deep breath, push on the other side, have them take a deep breath. Which nostril gives you the best airflow? Because that's going to be the one that's going to easily pass the tube. So for this patient, I'm going to go on this side because both sides were equal. Setting up your supplies, you need a catheter tipped syringe, some tape, some water soluble lubricant, your tube, which in a real patient would be in a sterile package. This is the suction connector, so I usually go ahead so that I don't lose this because it'll roll off the table and everything else. I'm just going to attach it to the end of the suction. And then you need a pH strip. So that's one of the ways that we're going to check placement for the NG tube. Now, a cup of water. This will be facility policy whether you put them in with this or not. If we're going to hook this patient up to suction, it doesn't matter if we give them a few sips of water to lubricate the back of their throat. So I'm going to give that to my patient and I'll instruct him when he's ready. And the only other thing I need is a pair of regular clean gloves. Remember, your GI tract, not sterile. The food you put in your body is not sterile, so we don't have to be sterile. Now, I don't want to be flip-flopping this around. Okay, I'll look for them. They're here somewhere.
I haven't seen them in
Okay,
a while,
I'll find them. They're here.
so.
They're in a cabinet somewhere.
I figured, oh, well.
She should be here shortly. She's
Well,
usually
that's
here
what I
early.
figured, but-
Okay. All right, so my patient's ready. I'm going to use the right nostril. I'm just going to pull one small piece of tape just to hold it in place for now. Okay. Measuring your tube. Make sure you close it. You do this, and you put this in this patient, everything in their stomach is going to fountain right on out of the top.
There's boo-boo in your stomach. You don't want
It's
that.
gross. So, measure. Tip of the nose to the earlobe to the xiphoid process. Nose, ear, xiphoid process. Okay? Now, most of the tubes nowadays are all marked with measurements. If it wasn't, you could put a small piece of tape on there, make a mark on the tubing so you knew where you were going. We're going to the 45 centimeter mark. Okay? So I'm going to go ahead and put my gloves on. I'm going to lubricate my tube. Now, if you're worried about the patient vomiting, getting sick, that kind of thing, you can get a towel or a chucks to put over their abdomen if you want to. You want your patient initially to be looking at the ceiling so that you're going into that nasal passage pretty straight. Then when you get to the back of their throat, you're going to want them to lean forward so that you're angled down the back. So I'm going to have my patient lean back, and I'm going to insert the tube. And when you hit the back of their throat, they're going to start to gag. Have them lean forward, have him take small sips of water, and every time he swallows, and don't do this slowly. Because I watch some students and they're like, I'm like, just push. Because they're going to continue to gag. Now, in the mannequin, his stomach is up here. So I'm supposed to get to 45 and I'm barely at 25. We know that. So you would just say in your CPE, I would go all the way to my 45 centimeters. Now, I'm just going to temporarily tape it here. I don't want to use too much tape if I'm not in the right spot. So what I'm going to do is I'm going to kink my tube. Make sure you kink it or you'll wear it. I'm going to hook up, and this is just like in 155 when you guys did your tube feeds, only we're not checking residual. We're just checking a little bit of what's in here. So I'm going to pull you don't even need a couple milliliters. And I'm just checking to make sure it's acidic. Your stomach should range somewhere less than 5 on the pH scale. So I'm going to put my pH strip in here. I'm going to test it. Sure enough, it's in the right spot. But that's not enough. We're going to have to send this patient down to X-ray in order to verify placement. So before I send him off the unit, I'm going to go ahead and tape his tube in place. Now, if I can find some, we should have some somewhere, I'll show you guys. Most of the time you're going to have the tubing holders. It looks like a flesh-colored Band-Aid goes over the bridge of their nose and has a piece that you wrap around the tube. If you don't have that, you take a piece of tape, rip it like a pair of pants, put this part across the bridge of their nose, wrap one leg one way, and one leg the other. Then you can take this piece off the side of their face. And I use that same piece to secure it with a safety pin. Sometimes you'll see them do the securing with a rubber band. Just depends. All right, my patient's ready to either go to X-ray, have X-ray come portable to the bedside, and what they're going to do is they're going to X-ray here to here, and they're going to be able to visualize this tube. So they'll be able to call me and say, yes, it's in the stomach, push it forward, pull it back. They'll be able to kind of direct you on whether or not it's in there. You can't use this tube until you've got that done. So when your patient comes back from X-ray or X-ray calls and says the tube's in the right spot, now I'm just going to hook him up to suction. So I'm going to put on a pair of gloves. I'm going to check my suction to make sure that it's set at the right level. I flip mine to regular just to check the suction, because otherwise you're going to have to wait for it to cycle. Okay, it's 80 to 120, so I'm going to flip it off. Again, I'm going to kink the tube, and I'm going to connect my suction. You want this blue pigtail to be free hanging so that it doesn't, now this is a one-way air valve so that it doesn't suck up the, unfortunately someone's got it in there. No, it's in there right. So that it doesn't suck up like the sheets or like getting your vacuum cleaner stuck on the curtains. The idea is with this, the tube will not suction itself to the wall of the stomach. If we didn't have this and it got attached to the stomach, it would just suction up the tissue of the stomach. So if you don't have these little valves, just make sure your pigtail is hanging freely. And never ever connect your suction to this. So make sure that your suction is connected to that piece. I'm gonna flip it to intermittent. And while I'm cleaning up my mess, I'm gonna watch. I'm gonna watch to see how the patient tolerates it. I'm gonna watch to see what's coming out. And what you're gonna get out of this is gonna be widely varied. Depends on how much of an obstruction, how deep it has gone, is there blood, is there, what has this patient eaten? At some point, the suction should really subside to just a tiny amount. And at that point, you've emptied them. Now you're just gonna get gastric juices that the stomach's gonna keep creating. So once that suction slows down, then you're gonna wanna look at your suction container. And it's gross. Green, brown, black, any number of colors that you're gonna find. And so I wanna look and say, okay, my suction has pretty much subsided. I'm not getting much else out. I've got 300 mLs of greenish brown fluid, thick and cloudy, and that's how I'm gonna document what I got. Other key documentation pieces, which nostril and which centimeter marking. Because each consecutive nurse is gonna look at your documentation and be like, oh, okay, so the NG tube is into the 45 centimeter mark. The start of their shift with assessment, they're gonna look to make sure it's still at the 45. Okay? Questions?